new kid in the block. Conventional versus interventional. So the coordinators are Professor Vijaya ma'am and Dr. Karpahambal Sairam, and speakers for today is Dr. Ekta Biradar and Dr. Ramani Devi ma'am. Jayamina is again going to talk on carbitazone, which is a new innovational drug. And now to this, I request our President, Professor Sampath Kumari Madam, who is Professor HOD OG Sri Muthukumaran Medical College and Hospital and Research Institute. Over to Sampath Kumari Madam to give the welcome address.
Yes. Good evening to all, and I welcome you all, especially Dr. Ikta and Dr. Jaimina and Dr. Ramani for participating in this program. And I welcome the coordinators who is doing continuously, Dr. Vijaya and Dr. Karpahambal, for this Vivadham series. This Vivadham series is not a debate. So in the some places we are using we are following one type of protocol. In other places the other protocol is followed. So we want to know how we are updating the protocols. So for this today we have taken the Syntocin as the main thing for the Vivadham. Previously, we used to follow the Amstel, that is to prevent the PPH, active management of third stage of labor with 10 units Syntocin. Now, in many hospitals, we are following the carbitazone. Both is good. We don't tell that both is not working. Each has its own advantage. And what is how we are updating, and why in some hospitals they are continuing with the oxytocin, and why in some they are going with the carbitazone. That will be moderated by our past Vice President of Oxy and past President of Trichy Society, Dr. Ramani Devi Chennappan. Now I invite our coordinator, Dr. Vijaya. She was our past President of Chennai Society Oxy, and she will conduct the programs. Dr. Vijaya.
Thank you so much. Chitrakala. Yes, no need for this.
Welcome, Ramani ma'am. Ramani madam has joined, madam.
Yeah, saw that.
Okay.
Doctor,
1 minute. Dr. Vijaya, 1 minute. Ramani madam, Vanga Vijaya, Unglada Solitaire, no, Antiga, correct. Dr. Vijaya was the past director of IOG, and now she is working as a professor in ESI Chennai, and she was the past president of Oxy. And she has many government trainings and all master training. Now we'll go with the scientific session. Welcome, Vijaya. Ramani madam, theatre ku போறீங்களா போயிட்டு வந்துட்டீங்களா?
வந்துட்டேன், முடிச்சிட்டேன்.
சரி, okay.
I'll be here, don't worry.
The ரெண்டு பேருமே present பண்ணுவாங்க madam. One will present with oxytocin and carbitazone.
And the critical evaluation அவ்வளவுதான்.
That's all. Okay, madam. Thank you.
Now my pleasure to introduce Dr. Ekta, and this session is mainly to encourage what are the newer things and that has come into, and whether it is beneficial or it is more safer than the conventional. That is why all these series are based on magnesium sulfate regimen, and also the PPH, and also now the oxytocin. So every time the newer thing is taken for the discussion. And now we will, I ask Ekta Pradar, she is a UG and PG from Adi Chunchungiri Institute of Medical Science, and she's a senior resident at Stephens Hospital, New Delhi, and she's presently working as an assistant professor in Patil Medical College and research in Vijayapura, and she's done in fellow in urogynecology in the same institute. She's done many posters and papers, and very young assistant professor. Welcome, Dr. Ekta. And
thank you, ma'am. Thank you so much, ma'am.
Yeah, thank you.
Ma'am, I'll share my screen, ma'am.
Yes.
Yes, ma'am.
Vidya will do many more programs after 2 hours. We will see what is happening.
Yeah, ma'am. Make it as a slideshow, full screen.
Yes, ma'am. So, good evening to all, ma'am. I'm going to talk about oxytocin, which is a conventional drug. So let's see what is oxytocin. Oxytocin is a naturally occurring peptide hormone which is produced in the hypothalamus and it is secreted by the posterior pituitary. And it is a well established drug with a long history of use. It is a widely used as conventional drug in obstetric for its strong uterotonic actions. And it is also considered as a gold standard for induction and also for augmentation and prevention and also for a treatment of postpartum hemorrhage. So, what are the receptors of oxytocin? We'll see. It is
Ma'am,
secreted.
sorry to interrupt. Your slides are not moving and it is not in slideshow mode. Can you please stop share and share
So,
once again?
Stop sharing, I'll do, ma'am.
Yes.
yeah.
Please select the screen option, ma'am, instead of selecting the PPT.
Yes, ma'am.
Yeah.
Is it coming, ma'am, now?
No, ma'am.
Not coming. Click again.
Hey, if
That
needed, you can send the PP to Dr. Meena. She will present or Chitrakala, whichever is
Yes.
comfortable.
You can try once more. Otherwise, please
Ah,
share the PPT.
put that same thing and make it as a slideshow. That was good only. But click on the top. Share it again.
Yes, ma'am.
Click on the green color share icon, ma'am. Then click on the screen option and then blue color share.
Share screen, I'll do, no, ma'am.
Share the screen. இருக்கு இல்லையா? Just share that green button. You can press on the screen button. It's coming as share screen. Ekta.
Yes, ma'am. It is coming as share screen, ma'am.
Yes, ma'am.
Then click on the
Then
screen button
again
and
share. Again share. There is a bottom blue color share icon.
Chakala, did you check earlier? You should always check earlier.
Uh, she did it that rightly, but the slideshow was not working.
Okay, no issues. But anyway, we can see the. You share that only. It's a scene.
Yes, ma'am. Yes, ma'am.
Share that only. It's okay.
That was not moving, ma'am. When
Not
she was
moving at
moving,
all.
yes,
She
ma'am.
not moved. She was in the first slide only.
Second slide she moved, ma'am.
Moved. Okay, okay. Let's check. Let's check.
Ekta, if you're not able to do, you can share it to us.
Yes, ma'am. Yes, ma'am.
Meena driving.
இல்ல மேடம், உங்க வீட்டு பக்கத்துல தான் பிளாக் பண்ணி நின்னுட்டு இருக்கேன்.
சரி வந்துடுறேன் வீட்டுக்குள்ள வர வேண்டியது.
இந்த லெஃப்ட் ஏதோ பிளாக் பண்ணிருக்காங்க மேடம், நிறுத்திட்டேன்.
சரி சரி. நீ வேணா உள்ள போய்க்கோ, அது வரைக்கும் நான் பாத்துக்கிறேன்.
இல்ல இருக்கட்டும் மேடம், ஸ்டார்ட் பண்ணிருக்கேன்.
Meeting ID.
Ekta, என்னடா, what's happening?
Yes, ma'am. Yes, ma'am.
You have shared, Ekta?
Um,
You can share the slides to us.
yes, ma'am. Which number?
98418
98418
22664
98418
22664.
664. Yes, ma'am. I'm sharing, ma'am.
Geeta.
Yes, ma'am.
Okay. Yeah. The Ekta, it's there.
Yes, ma'am. Yes, ma'am.
Start.
Yeah, you can start.
Yes, ma'am.
Can you see?
No, ma'am, I can't see.
Open, you can do it from your mobile.
Yes, ma'am.
Just click on the link from your mobile.
ஏன் மீனா நீ வாங்கி பிரசன்ட் பண்றதானே?
மேடம் ஷேர் பண்ணியாச்சு மேடம். அவங்களால பார்க்க முடியலன்றாங்க பிரசன்டேஷனை.
அவ மொபைல்ல
Oxytocin is a naturally occurring peptide hormone which is produced in the hypothalamus and it is secreted by the posterior pituitary. Oxytocin is a well established drug with a long history of use. It is widely used as a conventional drug in obstetric for its long uterotonic actions, and it is considered as a gold standard for induction and augmentation, also for prevention and a treatment of postpartum hemorrhage. Now, receptors of oxytocin, it is secreted endogenously by hypothalamic nuclei. Oxytocin is mainly secreted to cause uterine contractions, and receptors are not only present in the uterus, but it is also present in other tissues like limbic systems of brain, heart, breast, and also a spinal cord. They belong to a family of G protein receptor family. Now, next, what is the pharmacological actions? Oxytocin, the principal action involves binding to oxytocin receptor situated on the myometrium, thereby precipitating intracellular signaling cascade conducive to uterine smooth muscle contraction. And also, it helps in milk injection reflex, causes contraction of myoepithelial cells which are present in breast that also facilitates breastfeedings. And what is the structure? Let's see. Oxytocin contains a disulfide bridge, which is formed between two cysteine amino acids at position 1 and 6, which contributes to stability and its biological activity. This structure features as a crucial for its physiological actions, functions, including uterine contractions. Now, what are the pharmacokinetics? Oxytocin can be administered via IV, intramuscular, or even intranasal routes. Intravenous administration ensures a rapid onset of action within 1 to 2 minutes, while intramuscular administration leads to slightly delayed onset, typically within 3 to 5 minutes. And it is metabolized in the liver and it is excreted primarily through the kidney via urine. Now, what is the dosage? It varies on indication. For induction of labor, intrafusion infusion starts from zero point 0.5 milliunits per minute and gradually titrating until adequate contractions are achieved. Higher initial dose may be required to manage postpartum hemorrhage. Its half-life is only 3 to 5 minutes. Now, what is the various clinical use we all know about oxytocin? It can be used in induction also, augmentation of labor also, can be used in prevention and treatment of postpartum hemorrhage both, can be used, we all use in active management of third stage of labor. It also facilitates the breast milk that is milk let down reflex. Now, what oxytocin during pregnancy, labor, and delivery? Oxytocin and its receptor increases during pregnancy in preparation for labor and delivery. During labor, peak level of oxytocin are released into circulation, which induces uterine contraction to allow the birth of the fetus. Immediately after delivery, the peak level of circulating oxytocin stimulates uterine contraction to expel the placenta, and that helps us for lowering the risk of PPH. Moreover, oxytocin is released in response to breastfeeding to contract the myoepithelial cells of mammary gland to promote milk injection reflex. In addition to these classical contractile effect of circulating oxytocin, oxytocin is released from the neurons with brain, exerts important adaptive, physiological, and psychological effects. Oxytocin infusion protocol we are going to see. Oxytocin infusion protocols for labor induction and augmentation differ widely, and important infusion protocol components includes initial increment and maximum dose with interval periods between titration. According to ACOG recommends that every hospital should develop oxytocin administration guideline that may include both low and also a high dose of regimen. Low dose oxytocin protocol starts between zero point 0.5 to 2 milliunit per minute with incremental increase to 1 to 2 milliunit per minute every 15 to 40 minutes. And high dose protocols start between 4 to 6 milliunit per minute with incremental increase. Now, oxytocin versus carbetocin in PPH, what is the difference? Oxytocin, it is a synthetic cyclic peptide from a naturally occurring posterior pituitary hormone, and it causes contraction of smooth muscle. Carbetocin, whereas it is a synthetic analog of oxytocin. Pharmacokinetic wise, oxytocin peaks after 30 minutes and the half-life is shorter as compared to carbetocin. Half-life of oxytocin, we all know it is 3 to 5 minutes, 3 to 6 minutes, whereas in carbetocin, half-life is around 40 minutes. Storage and transport has major difference between oxytocin and carbetocin. Oxytocin is just 2 to 8 degrees Celsius, whereas carbetocin storage is up to 30 degrees Celsius. Induction of labor and augmentation of labor both can be done by oxytocin, but carbetocin disadvantage is that for augmentation of labor, we can't use carbetocin, can be used for induction of labor. We can't use for both, even augmentation and induction of labor. When we see PPH, for the prevention of PPH, oxytocin can be used, and as well as it can be used for the treatment of PPH, whereas carbetocin only can be used in case of prevention of PPH, but cannot be used in case of treatment of PPH. According to WHO guidelines for the management of PPH, the first line treatment is oxytocin used in the dose of 20 international unit in 1 liter of fluid at 40 drops per minute and can go up to 40 international unit. Carbetocin is heat stable, longer acting. However, it is expensive and less likely to be present in all peripheral healthcare systems and likely to be inferior to oxytocin when it comes for the prevention of PPH. Why it is conventional choice? Because it is cost effective and it is reliable, it is inexpensive, widely available, and predictable uterotonic effect. We all know about its predictable uterotonic effect. It has rapid onset when given IV. Safety profile as compared to carbetocin, it is well proven. About oxytocin, it has been safely used for decade and clinicians all are well trained in its use. And also we know about flexibility of use. Oxytocin can be used for multiple purpose: induction, augmentation, active management, treatment of PPH, and also we know about the breastfeeding effect. Now again, the difference between oxytocin and carbetocin. Oxytocin is a conventional drug. Carbetocin is a synthetic analog. Oxytocin is very cheap and first line for PPH prevention and the treatment, whereas carbetocin is just an alternate source present only in a high resource setting. Oxytocin has multiple functions. Carbetocin, we have limited functions, and oxytocin is well studied, documented, used for decades, whereas carbetocins, all have less clinical experience now. It is coming up right now, but as compared to oxytocin, we have less clinical experience as compared to oxytocin. Carbetocin has less clinical experience. And at the last, I would conclude by saying that oxytocin is affordable, accessible, and trusted global standard for obstetric care. And it is a universal lifeline in obstetric care. Thank you, ma'am.
Thank you, Ekta. Summarized nicely. I think we should ask Jayamina to tell, and then Ramani madam, would you like to conclude in the last?
No, let them finish. Let both of them finish. Then
Yes.
we can compare and contrast.
Yeah, can I have the slide of Jayamina, please? Jayamina CV? Jayamina is very, very sincere and very, what should I say, helper for Oxy. That's what I should say. Anything she can be the part of Oxy, especially with Sambat ma'am. And she's the assistant professor of Muthukumaran Medical College. She was an undergraduate at Meenakshi and a PG from ESI Medical College, Kolkata. And now she's a co-author in Foxy Focus on High-Risk Pregnancy in Adolescent. And very, very nice to girl to be with us, all of us in Oxy. Welcome, Jayamina, and over to you to talk on carbetocin. Unmute, Jayamina.
Yes, ma'am. Thank you, ma'am. Thank you so much for the introduction, ma'am.
You are not seen only. Where are you? Your video is not seen.
Hello. Excuse me, ma'am. Is it audible, ma'am?
Yeah, audible, but screen.
Yes. Yeah.
Yes, yes.
Okay, ma'am. Thank you so much for the introduction, ma'am. I would like to thank the organizers for giving me this opportunity. Now I'll start with the presentation. Good evening to one and all present here. I'm going to present a topic on carbetocin, a new and innovational drug. So coming to the introduction, so uterotonics are actually a chemical compounds that increases the tone and contraction of the smooth muscles of the uterus. Uterotonics can be used for labor augmentation and during the postpartum period. The WHO mainly recommends the use of uterotonics during the active management of third stage of labor to prevent postpartum hemorrhage. So some of the commonly used uterotonics in a day-to-day practices are oxytocin, ergometrin, and misoprostol. Since 2018, carbetocin has been proved effective in preventing postpartum hemorrhage. So a little bit about the history of carbetocin. Carbetocin is nothing but a synthetic analog of oxytocin. It has been developed since 1964. But what was initially developed was not heat stable and it required refrigeration. But in 1997, a new heat stable carbetocin was developed. And what we use currently is the heat stable preparation. There is only a small difference in the chemical composition between the heat stable and the non-heat stable form of carbetocin. So coming to the heat stable carbetocin, so the carbetocin is a synthetic analog of oxytocin, which means the metabolism, the excretion, and all the types are a little bit similar to the oxytocin. Only thing that it is different is the heat stable variety and the long T half. So that's what the heat stable carbetocin is known for. It has a similar mechanism of action of oxytocin, like binding to the uterine smooth muscle receptors and causing uterine rhythmic contraction, which with a longer half-life. So the heat stable form of carbetocin, which the dose required for preventing of primary PPH is 100 micrograms given IV or IM over 1 minute in the active management of third stage of labor. So my previous speaker has already spoken a lot about the comparison, so I would just keep it very short. In comparing to oxytocin and carbetocin, we can see there's just a slight error in the table. It is carbetocin. We can see that the IV and the IM preparations both can be used, while the IM having a longer T half than the IV preparation of carbetocin. The half-life of carbetocin is close to 40 minutes, whereas the half-life of oxytocin is only about 1 to 6 minutes. So you need a continuous infusion of oxytocin to maintain the effect, whereas a carbetocin, a single injection given IM or IV is enough, and it is also heat stable, so it doesn't require any refrigeration. So according to the WHO Champions trial, which was conducted to prove that carbetocin is used in the prevention of primary postpartum hemorrhage. It was concluded that carbetocin is as effective as oxytocin in preventing PPH. So the WHO added the carbetocin to the core list of reproductive health medicines in 2019. Because the champion trial was concluded in 2018, so following which the WHO has added carbetocin to the 2019 to the list of reproductive medicines, essential reproductive medicine. So this is the protocol given by WHO for the primary prevention of postpartum hemorrhage. So we can see that if we don't have a cold chain transport available, heat stable carbetocin or misoprostol comes as a first line of drug for prevention of primary postpartum hemorrhage. Only if the cold chain is available and skilled birth workers are present, we use oxytocin. If cold chain is not available, we do go to heat stable carbetocin or misoprostol. So what are the advantage of carbetocin is, first, we all know it is heat stable, so there's no need for any cold chain to be maintained. So it saves us a lot of cost in maintaining this cold chain. And also, we come to the second advantage is that it has a longer T half, so you don't need continuous infusion to maintain the uterine contractility. So coming to the contraindication, we cannot give carbetocin for the labor augmentation or induction. We can also not give if the woman is suffering from any cardiovascular diseases, kidney diseases, liver disease, or epilepsy. And also if the patient has any known hypersensitivity to the carbetocin component or any of its preparations, we cannot give carbetocin in that case. So we all know that the impact of PPH on the maternal mortality is very high. It is estimated that PPH accounts for about 20% of pregnancy-associated deaths worldwide. So it has been proven that if prompt prevention is given in PPH by giving prompt uterotonic and in the active management of third stage of labor, we can prevent PPH-related mortality, according to the FIGO guidelines. So we have a study conducted in our college by a postgraduate student, which between oxytocin and the carbetocin. It has proven that carbetocin group resulted in less blood loss when compared with the oxytocin group. Among 150 pregnant women, they were divided into two groups. One received oxytocin, the other group received the carbetocin. But at the end of the trial, at the end of the study, it was seen that the carbetocin group had lesser blood loss when compared to the oxytocin group. So these are some of the studies which have published that carbetocin, when used, prevents postpartum hemorrhage in low-risk women, and also in high-risk women. It has been shown to decrease the postpartum hemorrhage and also prevent further use of uterotonics or blood transfusion. Because one of the main disadvantage of carbetocin is the cost factor. So the WHO is working along with the manufacturer to make it available for the low and the middle income countries where the PPH mortality is high. So I would like to conclude by saying that carbetocin only requires storage at 30 degrees Celsius. It can be stored for up to 3 years. One dose of carbetocin is considered equivalent to 16 hours of infusion of oxytocin. And it should be noted that carbetocin is given only for the prevention of PPH and not for the treatment, or also not for augmentation. And heat-stable carbetocin was found non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of any additional uterotonic agents in various studies conducted across the globe, including women from various ethnicity and origins. So these are my references, and thank you. I hope the presentation was useful to all of you. Thank you, ma'am.
Jaimina, it was a good presentation. I have certain questions to you as well as the previous speaker. Okay?
Yes, ma'am.
Yeah, okay. So for you,
Yes, ma'am.
what are the indications you use carbetocin in your clinical practice?
Ma'am, the only indication where I use carbetocin is in the low-risk women for active management of third stage of labor, ma'am. Where
Okay,
after the delivery of
the
the
next
baby, we
question
give
is,
100 micrograms.
okay, 100 micrograms, you are giving either IV diluted or IM. Okay. The time taken,
Yes, ma'am.
that is the half-life period is shorter, and it persists. I mean, half-life period of carbetocin is quite long, so you don't need to give the additional oxytocin. See, but how many
Yes,
of
ma'am.
you, how many percentage of the low-risk group, they go for carbetocin? You say they really need carbetocin.
Ma'am, actually, carbetocin is given for low-risk women. It's only the cost factor which is preventing them from usage along the groups, ma'am. Because one
So
vial costs around 250 to 300 rupees.
300 rupees. So it is not only the cost factor,
Not,
and it has got lot of restrictions, as you have pointed out, the contraindications. And
yes,
we know
ma'am.
now the
Yes, ma'am.
hypertensive disorders are quite common. Eclampsia, it is
Yes,
contraindicated, and in cardiac disease, you cannot use it. In renal disease, liver disease. So your role of
yes, ma'am.
carbetocin is confined only to the low risk population without any comorbid
Yes,
conditions.
ma'am.
And of course, diabetic patients you
Yes,
can
ma'am.
give. So you agree for that. Okay,
Yes,
then
ma'am.
the main
Yes,
advantage,
ma'am.
what is the main advantage of using carbetocin?
Ma'am, it is a single time, one time. If you
Okay.
give, the T half is long, ma'am, and it reduces the postpartum hemorrhage. Volume of blood loss during delivery is reduced.
Yes, only for prevention of postpartum hemorrhage. So what is the
Yes, ma'am.
content
Only for
of the,
prevention, ma'am.
yeah, what is the content, conclusion of the champion trial?
Ma'am, in champion trial, they concluded oxytocin versus carbetocin when given for the active management of third stage of labor. Carbetocin group was associated with lower blood volume loss. It was similar
Yes.
to
So
oxytocin in
there is
preventing
no need
postpartum
for
hemorrhage.
requirement of blood transfusion was very much lower in the carbetocin group.
Yes,
And
ma'am.
also
Yes,
there
ma'am.
are 3 points which you mentioned in your PPT. One is there is no need for additional blood transfusion, no need for
Yes, ma'am.
additional oxytocic agents, and the hemoglobin fall is not much when compared to the oxytocin group. So these are the
Yes,
3
ma'am.
advantages. So you now
Yes,
tell
ma'am.
me in a, I mean, very few points from your topic, what is the role of carbetocin? How it scores over
Ma'am,
carbetocin? Repeat it, but anyway, it's all.
ma'am,
uh,
ma'am, point number one would be that carbetocin is a single dose administration. There is no need
yes,
for infusion or repeated dosage, ma'am. That is the major
yes.
advantage of carbetocin. And it can be given both during cesarean and vaginal delivery.
Ah,
And the requirement of blood transfusion or further uterotronics is markedly reduced in the carbetocin group because of its longer T half. And the cold chain problem that we have with oxytocin is not there with carbetocin.
Not there with the carbetocin. Okay, now coming to the other
Yes.
speaker.
Yes, ma'am.
Dr. Ekta, your
Yes, ma'am.
presentation was also very crisp. In fact, this Vivadham topic is very good because the person who listens to it will have only the crux of the topic.
Oxytocin.
So
Yes.
now, to tell me oxytocin, how it scores over, or rather the advantages of oxytocin over carbetocin.
Ma'am, oxytocin, the main advantage what we have is a cost, ma'am. It can be used in low
Okay.
resource setting, ma'am, and all
Okay.
primary health centers, oxytocin is available. So it can be used, and we use for various reasons for augmentation for the treatment. And when it comes to PPH is so common. Mortality is one of the highest risk of maternal mortality is PPH. So oxytocin, in spite, even if the carbetocin is not present in a setting, we'll have oxytocin for the prevention of PPH and also
So,
for
one is augmentation, it can be used.
yes, ma'am.
Second one is
For the treatment
prevention of PPH.
PPH.
Third one is, even if you have PPH, you can use
Use
oxytocin.
Yes,
And
ma'am.
another thing is the side effects, like rather the contraindications for oxytocin when compared to carbetocin. We can safely use it in hypertensive disorders.
In case of epilepsy, we can use. In case of
Yes.
renal diseases, we can use. In case of
We
unknown
can
cardiac diseases,
use.
when there is a
Any
high risk
cardiac
centers.
disease also we can use.
Yes,
So
ma'am.
even if you don't have an IV line, oxytocin IM can be safely used,
safely
similar
used.
to carbetocin. So, but the only disadvantage of using carbetocin is it has to be preserved in the
In the refrigerator.
the refrigeration is needed.
Needed,
It is
yes,
not
ma'am.
stable at hot in the room temperature. So
Yes.
that is one advantage. And more than that, we have been using oxytocin for time memorial period. It
Yes,
has
ma'am.
got ultimately the side effect, that is the contraindications or the adverse effects of oxytocin. Have you anybody come across adverse effect of carbetocin in the form of allergy? It is
No, ma'am.
practically nobody would have seen.
No, ma'am. No,
So
ma'am.
carbetocin is is the uterotonic drug of the women with low resource setup, and of course carbetocin can be given for high
High
resource
resource setting.
setup. So the main advantage is when you anticipate postpartum hemorrhage, you give carbetocin.
Yes.
Okay. For example, if the patient is on multiple pregnancy or prolonged induction of labor with prolonged intrapartum period, what would you prefer for prevention of PPH?
Ma'am, the first choice will be oxytocin only.
Why?
Ma'am, because it will be like the first thing which will have oxytocin. It is like we will give oxytocin for the prevention. The
Okay.
first thing which comes in mind is start with oxytocin.
So, but I am telling it is a high risk pregnancy.
Yes, ma'am.
So when you know that the patient is likely to bleed, won't you get ready carbetocin?
We'll get ready, but
We have to.
yes, ma'am.
We have to get ready carbetocin. So in those cases, even when the patient is put on IV oxytocin for augmentation of labor, for prevention, can we use carbetocin or not in
Yes,
high-risk
ma'am.
patients?
Yes, ma'am.
Yes.
We can
So
use.
that is supposed to. So already prolonged labor patients, they are likely to have slightly excess bleeding.
Yes, ma'am.
Okay, so that can be avoided. So the need for transfusion, need for fall in hemoglobin, all those things are reduced. So
Reduce.
ultimately, give a single, say 1 or 2 points to say that oxytocin is your choice.
Yes, ma'am.
Tell me.
Ma'am, in high risk cases, we will keep ready. Carbetocin will
Okay.
keep it ready, ma'am. But first, we'll rule out like CVS disorders, renal disorder, liver disorder, which is very common in high risk obstetric, which is very common. So in those cases, we can't use carbetocin. So oxytocin invariably we have to give to the patient, ma'am.
Okay. Suppose you are putting the patient on carbetocin. Still, she continues to bleed. Because we cannot say that all patients put on carbetocin will have control of postpartum hemorrhage.
Yes.
It is only for prevention. So when you see slightly excess bleeding also, you can start giving carbetocin. So, but add to that, you can continue with
We can continue with oxytocin because it is
oxytocin.
IV titrating dose. It will be continued from oxytocin.
Yes. So that is the major advantage. It is a oxytocin is a poor man's drug and carbetocin is a rich man's drug. So
Yes.
now this is to Meena. Meena, you have said that you had done a study on comparing
Yes, ma'am.
carbetocin versus oxytocin. Was
Ma'am,
all
yes.
the patients who delivered carbetocin versus oxytocin? Okay, did they deliver vaginally or they were taken for LSCS?
Ma'am, it included both LSCS and vaginal delivery, but they were low risk, ma'am. They didn't have any complications. Maternal or fetal complications were not there. It was in a low risk population.
Okay. So you found that the carbetocin was non-inferior to oxytocin, needing less
Yes,
of
ma'am.
blood transfusion and bleeding. Okay, that's good. So in my practice, I
Yes,
will
ma'am.
tell you where carbetocin I use. I routinely use carbetocin
Yes,
for
ma'am.
all my LSCS patients for prevention. Okay, that is the
Yes,
major thing.
ma'am.
LSCS
Okay, ma'am.
patients who are electively taken, it can definitely
Okay,
reduce
ma'am.
the amount of volume of blood loss. So that is point
Yes,
number
ma'am.
one. And in normal labor, patients who are undergoing normal labor, if the
Yes,
patient has
ma'am.
been put on a prolonged, like say, for example, she has been on a pitocin augmentation for about 5 to 6 hours, and the second stage of labor is slightly prolonged, or instrumental delivery, maybe in those
Yes,
cases,
ma'am.
I use carbetocin. So,
Yes, ma'am.
follow up, and of course, you can follow the maintenance with oxytocin also.
Yes,
So,
ma'am.
I think you have both of you have beautifully explained what is carbetocin, what is oxytocin, what is the indication, and what is the dosage, what is the half-life period, and everything, and contraindication. So, to practically to say that carbetocin has got certain restrictions over oxytocin, because oxytocin definitely has got no role for, contraindications are very low. And somebody
Yes,
has
ma'am.
written that is, of course, for a multiple pregnancy. Multiple pregnancy, always you expect a profuse bleeding. So, in preventive aspect itself, we can give carbetocin. So, carbetocin can be given in prolonged labor or in patients who have not entered the labor where they are not sensitized to oxytocin, that is in elective cases, and over distended uterus, you can give carbetocin. So ultimately, the champion trial has said that it is non-inferior. Carbetocin is non-inferior to oxytocin, and it has got selective role. We have to remember about the contraindication, and it has got a selective role that the results are there is reduced hemoglobin levels, reduced use of blood transfusion, and also the outcome is good. So we have to be very choosy when to use
Yes, ma'am.
carbetocin, to use oxytocin, because both are excellent drugs. And I think thank you, Ekta and Jayamina, for having
Yes, ma'am.
done a wonderful presentation.
Thank you.
And the participants, I would have,
Thank
I'm
you,
sure
ma'am.
it is a crisp, short presentation. They would have been definitely benefited by your talk.
Thank you, madam, for a wonderful discussion and
Thank you, ma'am.
points to be taken care. And thank you, Ekta, and thank you, Jemina.
Thank you.
Thank you, ma'am.
Yeah, can I ask Meena to give the vote of thanks? Yeah.
Yes, yes, ma'am. Yes, madam. Thank you so much, Ramani Devi, madam, for having given a crisp, clear explanation for both oxytocin and carbetocin, and excellent take-home points, which is as well said by Madam Ramani Devi, madam, crux of the presentation. Even though it's a very simple, short presentation by both Ekta and Jayamina, um, we had a lot of take-home points by Ramani Devi, madam. Thank you so much, Ramani Devi, madam. Thank you, Dr. Jayamina. Thank you, Dr. Ekta, and thank you, Vijaya ma'am and Karpahambal Sairam, for having coordinating the session so well, and also Dr. Chitrakala Shield for having given the platform. Thank you. Thank you, madam.
Jaya, all the best. Clock is ticking fast.
Madam, it has come, madam. Not yet. My name is not there.
Huh?
It has come. The other people have gone.